I want to first thank Assemblymember for introducing this legislation and the California chapter of the MS Society. It's an honor to be able to partner with you on such an important issue today. I first want to say I am the Executive Director of the Alliance for Plasma Therapies. I founded the organization because I felt it was important for patients to always have access to life-saving therapies and to never feel alone. I'm also a patient who has a number of autoimmune diseases, a bleeding disorder, and connective tissue disorder. A lot of them are rare diseases, genetic disorders, and I rely on a lot of medication to keep me going every day. And without it, I probably would be disabled. I'm lucky that none of them are on the specialty tier list. I can tell you that it mounts up to a lot of money, just the amount I take, but I'm fortunate because it allows me to do what I need to do. What got me involved, I would say, with my first case here in California was an MS patient who was relying on a plasma-derived therapy called intravenous immune globulin therapy, and it comes from human plasma, and it was keeping her going in a remission state. And her insurance company decided that it was considered experimental and medically not necessary. And she had went through all the appeals, and she had already been through all the other therapies, and it had failed. And so she appealed, and she lost her appeal and contacted me. And I worked with her, and I was doing about 250 cases a year and was successful in appealing those decisions. It took me 6 months to get her back on therapy. She didn't get back what she lost in that 6 months and is now in a progressive form. And that just tore me apart. But there was something we could do. We could appeal the insurance decisions. Then came specialty tiers and coinsurance. And like everything else, things tend to start with Medicare. And Medicare reform started something great in terms of giving us a drug benefit for seniors and the disabled. But it also gave us a drug benefit with a formulary, which was meant for people to go to retail pharmacies and pick up their medications, not for specialty pharmacies that are your infusible medicines, your injectable medicines, or your specialty medicines that were always covered under your major medical of your insurance policies. Nothing new. Insurance companies always covered it. But they found a new way to cover it and put it under the drug plan and put it under what they called Tier 4. And instead of paying a flat fee, $10, $15, $25, $50, all of a sudden wanted patients to pay a percentage of the cost of the therapy. What could that be? Well, it started increasing every year. And what happens in Medicare happens in private insurance. And it happens here in California. And it's throughout all of the healthcare plans. And so I started with a patient contacting me, of course, Medicare, Part D patient who has a autoimmune neuropathy. You know what his coinsurance was for 1 month? $4,000 for a therapy that keeps him from being paralyzed. Well, luckily, he fought for our country and he's a veteran, so he was admitted to the hospital for 5 days as an inpatient. From being at home getting his infusions to being in the hospital, what happens next if the VA system puts it in place? Because everything keeps them going, okay? This is what we're looking at. It's not unique. In Southern California, another patient contacted me, $2,000 for a month of her infusions. And this is a private pay patient. Can't afford it. Nobody can afford these things. Are there caps on these plans? Not all of them. Some of them yes, some not. And so patients have to make those horrible, horrible decisions. And this was never meant to be. And so you hear from the insurance companies, and I'm hearing this every day, your premiums are going to go up. Our premiums are going up. But every patient who is paying their health insurance and paying every day should not be denied their therapy, should not charge more because they got diagnosed with a disease and there's a therapy for them that can save their life and they're told that it's not affordable. That's not what this is meant to be. That's not what insurance is meant to be. It's discriminatory. We're talking about a small percentage of the population, each plan, who needs these therapies, and we're making it unaffordable. So as the days go on, and we hear from the health plans, talking about all these things, I want you to think to yourselves, what's going on now, and is that right, these policies in place? It's not. And we are having plans popping up in every state. A bill is being introduced, and it's time for all the patients and physicians, providers, all the sites of care, all of us to come together and unify. So I was hoping that this year will be the year of the patients, that we can speak up as loud as can be and say, no more, we're taking it back. And with the help of Assemblymember Ma, when we back up this bill, we've got a chance. If we could do it in New York, where New York passed a law to ban specialty tiers, and insurance is still provided in that state, we could do it here in California, and we could do it throughout the country. So I thank you all for your support.
Thank you, Michelle, for the very passionate insights. Finally, we'll hear from Mary Lou Liquinco, CEO of the San Francisco Medical Society, founded in 1868. The SFMS is a nonprofit organization that unites and supports the local physician community and works to improve the health of all San Francisco residents. Mary Lou?
Thank you. I am Mary Lou Liquinco. I'm the CEO of the San Francisco Medical Society, which is a component organization of the California Medical Association. So I'm speaking on behalf of the tens of thousands of physicians in California and the over 1,000 physician members of the San Francisco Medical Society. We've heard some really moving speeches today. I can't possibly top any of those. I just want to say that I think we all know that over the last 20 years, many of the diseases that we're talking about here today, there have been some great scientific advances in the treatment and the diagnosis of these diseases. Unfortunately, advances in science are only as good as the access that patients have to them. And today, I'm standing here to say that physicians in California have been fighting for years to reduce barriers to the access of drugs for financial reasons for patients in California. Doctors are in the trenches with the patients diagnosing these diseases. They don't expect that a prescription that they provide to a patient that is life-sustaining will be denied the patient because they can't afford to treat them. That's against the Hippocratic Oath. That goes against everything that medicine stands for. So we have been fighting this battle for many years. I'm here to say that we support reducing barriers to cost for medications, these medications, and that we'd like to commend Assemblywoman Ma, who we've been working with the Be Free Coalition for many years, and thank her once again for her efforts on behalf of patients. She's been a really fantastic advocate.
Thank you, Mary Lou, and thank you to all our speakers. We now can open up the questions to the floor for any of the speakers. Any of you have any comments or questions?
Well, this is the beginning of a 9-month process. So the bill has to go through my house first, the Assembly. It may go through one or even two committees, and then the Appropriations Committee, and then it will go through similar committees over on the Senate side before we eventually get it to the governor's desk.
Is there another vote that you need in the House?
Well, I mean, in each of the committees we need to have a majority vote. in each of the committees, and on the floor we need to have at least 41 members vote for it in the Assembly, and then at least 21 members vote for it in the Senate.
Plus, I understand, I don't know very much, I was educating myself on healthcare. I understand that you had another piece of legislature prior to this one that did not pass, and I mean, basically just people only little information. And that basically the result was that it was not passed, it was because it was too expensive. Can you speak anything about your experience with trying to pass healthcare legislation?
Yes, so I had a bill that would allow Medi-Cal recipients to get services if they had chronic hepatitis B. Right now, Medi-Cal only pays if you require a liver transplant or you are diagnosed with liver cancer, which is way down the road versus preventive care. Obviously, we don't have money at the state level right now, and so many of the bills that require any sort of funding get stuck in appropriations. Senator Wright had a bill last year that would bring parity to oral chemotherapy versus other types of drugs. I'm not a cancer expert, but if anyone knows anything about chemotherapy, his bill got stuck, but he is going to be presenting that again.
So something like this just recently passed in New York, which is really exciting, and I very much hope that California can do the same. Are there any challenges you think that would be unique to California and that could be the way?
Yeah, so the New York bill, we have experts here to talk about the New York bill, but as I understand, the New York bill capped the amount of copay that people would have to pay, but not the amount of out-of-pocket costs. And so we have now put in a maximum out-of-pocket cost so that there is not that loophole where providers can kind of increase as much, increase the copays, but then there's no maximum ceiling to how much people will have to pay. So that is different than the New York bill. Any other questions?
What will the first vote be?
The first vote, probably, I don't even know, we haven't even, it hasn't been assigned to a committee yet, but I would imagine in about 3 weeks. Yeah.
Dr. Goodin, can you give us some examples of what things that manufactured medicines has been categorized as a specialty?
I think virtually all of the medicines are. Yeah, so there are 6 really approved, actually 7 approved MS therapies. They include Avonex, Betaseron, Rebif, Copaxone are the 4 drugs that were sort of the standard drugs from 1993 up until 2006. Then Tisabri, which is another injectable drug, was introduced then, and then we just had an approval of a drug called Gilenya. And those are the 6 that are used predominantly. The other approved drug is a drug called mitoxantrone, which is a chemotherapeutic agent and has a lot of potential toxicity and is not one that's favored by most of the MS community, at least not in the United States. And I don't know whether Novantrone is tier 4, but I'm virtually certain that all the other ones are.
Well, usually, how long is the period before an endocrine drug can go public, being formulated, can be made into generic drugs?
Yeah, so none of these drugs are generic, and the first drug was introduced in 1993. And it's been a problem at the FDA in terms of how you actually validate these biological compounds, so that the drugs like the interferons are not your typical small molecule that you can then measure in a mass spectrometer or so, show the FDA that it has a certain effect in some cell system. And the FDA has struggled with how they even approve new formulations. So for instance, Rebif tried to make a new and better formulation, which is widely available in Europe, and the FDA has not approved that new formulation because they're not confident that that drug is as active as the original drug unless they go back and do another full clinical trial. So none of these drugs at the moment have generics, and I don't think that they are likely to have generics in the future. So I think that the people who have MS are pretty much stuck.